Good morning, everyone, and welcome to this important conversation on India's digital health and AI journey. Over the last decade, India had made a considerable progress and had emerged as one of the world's most ambitious digital public infrastructure ecosystem in healthcare, starting from ABDM, e-Sanjeevani, to rapidly evolving AI-enabled innovations across care coordination, service deliveries, be it screening, disease surveillance, and health system strengthening. But as we all know, digital transformation is not just about adoption of technology. We also have to think about continuity of care, equity, trust, workforce readiness, implementation reality, and most importantly, how we can ensure that health outcomes are getting better at scale. Today we have exceptional panel with us, bringing perspective from philanthropy, academia, implementation research, policy and health system strengthening. And we are looking really forward to having very enriching, grounded, future-facing conversation, to be honest, in terms of where currently India is standing in terms of digital health and AI ecosystem and where we are headed next. So maybe we can begin with Dr. Ajay. Uh, India is being increasingly viewed globally as a digital health success story among LMISCs. So, sir, based on your experience across large public health programs and digital health initiative, what are some of the most important lessons that LMISC should paying attention to from India's journey, particularly when we are moving from pilot towards population scale implementation?
Uh, Good morning, colleagues. Good morning to fellow panelists. Good to see a few friends and colleagues here after a long time. Uh, India has taken a lot of the pain of the journey in the digital health domain. If you look at from registers to Excel sheets, from Excel sheets to Google Sheets, from Google Sheets to applications, and there were pilots. So it was a time when we used to say pilotitis. There were so many pilots of various applications. But then ABDM came in where it laid down the ground rules of interoperability, standards, and what we can give to the world is that they don't have to go through this entire cycle of pain which we have gone and learned through. We have reached a place where we have systems which are operating at scale, and it continues to evolve. And from my role in developing some of the systems, one very important lessons which was learned was to always keep the last mile in the focus, which is the health worker. Because in developing in the anxiety or in the hurry to develop various portals and various platforms, we forget that what kind of effect it will have or a burden it will have on the health worker who has to deliver the data, and what use it gives back to that health worker. A study which we did with PGI Chandigarh shows that in 5 states or 6 states, shows that the amount of time given by a health worker on service delivery is almost equal to the amount of time she is giving to data maintenance, offline and online. So if we are wanting to improve the quality of care, if we are wanting to improve the number of services there, so we have to really look at interoperability. So these are the lessons, and there are already good examples which we can give to the as a part of the South to the world, where the systems are operating at scale, from applications to infrastructure at scale, that is something which we can give to the world as a part of our South-South partnership.
Thank you so much, Dr. Ajay. Those were quite insights. So the key things that we can take from this, that we necessarily don't have to reinvent the wheel, and should be focusing on the last mile, uh, basically frontline workers who actually will be using this technology. Coming to you, Maulik sir, uh, you have very closely worked with the ABDM implementation research and have seen firsthand what translating policy into practice look like. So, from your ground level experience, what would you consider are the, I would say, pivotal and critical achievement of ABDM so far, and what do you think ABDM 2.0 is, if I would say, now needs to focus on?
Firstly, thank you very much for having me here. I think so. The morning theme itself gave an answer, right? What Nation said, what Samir said, coalition,
Right.
the ability of bringing multiple stakeholders together when delivering such a complex program. And the reason I'm saying complex is because what you address, right? It's not only technology that needs to be taken to the doorstep. We are talking about a digital architecture, a highway which was created, right? Created first in a manner that it can meet a demand or need of multiple stakeholder. Now, creating an architecture with that kind of vision is crucial, because that's going to define your outcomes. Now, you need multiple players to get involved in making traffic or bringing traffic on the highway. And that's when, again, government played a fantastic role, both federal as well as state level. And I think so state level more than federal level, because health is a state subject, and they play a crucial role. And it will be seen in adoption of ABDM. And if you look at progressive states in terms of ABDM adoption, I think the state leadership has played a humongous role. But state leadership, again, cannot do everything on its own. So there can the play a role of interfacing agency as part of ABDM. There came a role of development partners like PATH, JAPIGO, Clinton Health Action Initiative, Excellence International, which again help in translating the ideas that National Health Authority had at a state level, because federal government can't go at each and every doorstep. So that's where they need. Again, we need to go at a doorstep of providers, practitioners, labs. That's where, again, the previous experience that we had in terms of interfacing agency, NHA was able to harmonize their efforts as well. So I think so the whole construct of ABDM of bringing in right a stakeholder at right point helped in making sure that there is enough supply side push.
Right.
Now that supply side push has helped us in creating fantastic numbers of achieving a fantastic number of HPRs and health professional registration or ABHA creation. But I think so the whole vision of ABDM is not creating HPR, HFR or ABHA. They want to make, and again what Samir said, and Ajay said, that we want data interoperability to be happen. Now that's a demand side function, right? Until and unless I demand my records to be digitalized, I want something that I want to share with someone in a digital form, it's not going to happen. And even though this HPR, HFR and ABHAs have been created, this interoperability is an area that needs to be cracked. And that's where ABDM 2.0 starts focusing on. How do we make consumers of this whole ABDM architecture a bit more demanding, that they want the digital health record, and that in other terms is adoption of public health record, PHR applications. So can we kind of empower community to make sure the demand is PHR application, and the demand then will push again on the payer side and supplier side to make sure they create a digital record. So I think so ABDM has evolved fantastically in creating a blueprint platforms and show the way that how things can work. But if it really needs to work, it needs to go at demand side, because again, we are talking about 70% of Indian rural population that needs to be mobilized, right?
Right.
And again, all these coalition partners coming together is extremely important for us to sustain it on a longer period of time. Thank you.
Thank you. Those are very enlightening insights. So, again, as Maulik has said, we definitely would have to focus on demand side of it, how we can empower the communities, and again how all the different partners come into a coalition and help supporting in actually translating the vision of ABDM. Coming to you, Dr. Anurag, you occupy a very unique vantage point at the intersection of academia, research, AI governance, and health innovation. How do you see academia eventually evolving to bridge existing training gaps in digital health and AI, and how you can think that digital health act as a cross-disciplinary sort of layer which connects technology, public health, clinical systems, and emerging innovations?
No, great point. In a recent meeting of our advisory board, somebody said very soon the word digital will go away in digital health because all health will be digital anyway. There will be no separate category called digital health. It will be like how does digital change health? Now within that, there are two rough directions in which one can think about it. One is today's health delivered by digital means, and one is tomorrow's reimagination of health in a digital age where you might even see things like babies being sequenced at birth, right? Both require very different type of training gaps and manpower. And it always comes back to the philosophy of a university. What is a university for? What is education for really? In the most pragmatic one, to make more productive workers in the job market, but also to create better citizens. And if you look at the previous comment by Maulik, supply and demand, some will cater to supply, but every citizen will cater to demand, right? So the interdisciplinarity that is required in today's world is to make people comfortable in the new digital age, even to the extent that I would say when we think of biology at Ashoka, we are making familiarity with computers and maths essential to biology major at Ashoka, because I cannot see a future where without that you can survive. We're also trying to see that institution without a medical school. We are probably planning to open a major in health science by next year, because health will change to a point well before disease. While today's medical is more about more reactive, but tomorrow's health could be simply about fitness maintenance and everything else. And one big leveler, very important in a youth forum, what has AI done? Every place where you see AI's effect on performance, it is the less trained that benefit the more compared to the experts. Youth by nature, simply by less years having passed by, are always going to be less trained, less experienced. And the use of AI allows them to borrow from others' experience. We're not thinking of AI as a person, but still, it can read a lot. And number two, AI truly democratizes a lot of skills and competencies. So in a coming world where information is already a commodity, knowledge is also somewhat a commodity, technical skills are increasingly commoditized. What remains are good questions. Where would you create impact? What needs to be done? Can you look at a situation, perhaps ask questions that haven't been asked before, see needs that may not even be apparent to the people who need it? And that's a classical liberal arts education, right? I mean, so that, in a very roundabout way of getting here, I think the future belongs to a liberal art training across multiple disciplines, comfortableness with digitals, computers, and AI as a horizontal that is not even about health, it's about everything.
Right.
And once you train people that way, I think the rest they will do on their own, and the youth are the best placed to benefit from this. And of course, all the hard work is being done by my colleagues here.
Thank you so much. Coming back to you, Anaita, you work at the intersection of funding strategy, digital health infrastructure, and health transformation. So, from your perspective, where do you think that investments made so far in digital health have genuinely paid off, creating continuity in the continuum of care pathway, and where do you still see important gaps?
Sure. Thank you for the question. And firstly, really nice to see so many young faces in the crowd, and a lot of experience in the crowd as well. So really appreciate everybody being here. I thought I'll break the ice a little bit between this side of the room and that side of the room. So maybe we've been talking a lot about patients. We've been talking a lot about demand, supply. Who is the patient, right? Is it you, me? So let's start with you and me. How many of us have abhas created for ourselves in the room? Raise of hands. Okay, great. That's not even majority. Fantastic. Of those who have abhas, or even if you don't have an abha, how many of you are actually accessing digital health records? You can count 1, 2, 3, 4, 10, 11 people. So that's the problem today, right? Like I just with a show of hands trying to tell, and this is, if I may, a privileged section of society. When we are designing solutions, maybe we are still designing for this section of society, but clearly there is a gap in what the section needs. But when we say last mile, like my fellow panelists were sharing from their experiences, there is a lot more work to be done to truly make this important. When I was coming in, I was reading the news today. India's National Health Accounts reported today that nearly half of the health account expenditure is still out-of-pocket expenditure in the country, more than 50%. Now, if that's the motivation or the lack of incentive that we have, are we truly, as a citizen at the last mile, thinking about whether I have a digital solution in my hand or not? Is that high priority for me? Or taking care of some of these real life challenges when I'm actually accessing healthcare? And how do I navigate the system better to achieve healthcare from an accessibility, affordability, availability, and most importantly, quality and timeliness perspective? Now, if all of that is important to your question around continuum of care, I need to be able to know what is the requirement at the last mile to be able to design effectively for it, whether it is reimagining or whether it is in the here and now today to truly make it effective, right? I think, like Maulik was also mentioning, on the supply side, a lot of work has been done in India leveraging the infrastructural guardrails that have been created through the DPI stack, the India Health Stack. We've also seen whether it is the WHO 6 building blocks around supply chain actually being made available, human resource management, truly being there, the ABDM building blocks truly making a difference of, even where facilities are actually available, what is the staff there, where can you access, so on and so forth. What we tried to do with some of our partners with the state government of UP, just to take an example on Continuum, I think sometime last year, was test out that continuum of care pathway. So the government of UP, just as an example, has rolled out a digital health application across the primary and secondary care continuum, and they also have something on the tertiary care continuum. But when it comes to interoperability, as my fellow panelists have been noting, that continues to be a challenge, where the Excel combination or the Google Sheet combination or different apps combination still comes in, even if these digital tools have been truly deployed for the frontline worker, for the MOIC, so on and so forth, right? But when they did this pilot end-to-end in one block for moderately and severely anemic pregnant women, they actually saw an increase just because of visibility in the iron sucrose level being actually deployed from a follow-up and referral treatment pathway. I think the point that I'm trying to make here is the potential is huge, but there are these actual gaps at the last mile which we need to work around when it even comes on the supply chain part. Now, moving to the demand side. My one-line response to your question would be, I think we've done a fantastic job as a country to be able to design for, at least set the right tone of the conversation when it comes to digitizing across the care continuum, and that's going to take its journey from an adoption perspective. But to Maulik's point, the rubber hits the road when or at the last mile, that woman who we are saying her iron sucrose increased, has the agency to actually demand whether she can access her health record, who she wants to share her health record with, when she wants to. There is a lot of stigma in society as well, right? So I think when we talk about PHR apps, when we talk about us also not using some of these tools, given the room, I would strongly encourage spend some time in the field to understand some of these gaps better, because you are designing for the solutions that are going to stick tomorrow, whether it is digital, whether it is AI, whether it's new emerging technologies we've not known the names of as well. I think it will be increasingly important. And the second point I wanted to make was on this, that there is a lot of science and R&D that's happening to truly make it translated into action at the last mile. We need to know what we are solving for. So even on upstream R&D work that we are doing, there is the here and now and there is the breakthrough. But in the here and now, what can we truly integrate with the digital layer that we have would be something that I would just leave as a thought for this room.
Thank you so much. One clear theme coming out of this discussion is that definitely we have to continue working towards the demand side of it, as we already have done a lot of work around the supply side and creating a basic architecture of the digital transformation. And as you have rightly said, Anita, there is a need to generate awareness amongst the community, the end users, and likewise, we might also want to work towards the improving the digital literacy part of the end users. So let's now shift our conversation slightly from digital infrastructure towards AI implementation realities and continuum of care. We already know that AI had already created an enormous excitement globally, but the real question always remains how we can use the AI responsibly and effectively while ensuring that it easily gets integrated into the real world public health system. Coming to you, Dr. Ajay, we already have seen a lot of expansion in terms of innovative AI tools coming up, but scale does not automatically translate into equity and equality, right? So in your experience, where are we already seeing AI begin to reduce inequities in healthcare delivery? And what future possibilities are you most optimistic about when we talk about adoption of AI?
AI, I feel, is the most, I shouldn't use that word, is the most, abused word. Less understood, most talked about, controversial, but much loved. So when we talk about AI in health, there's a lot of work to be still done. What we can do, I think we need to learn from private sector. How many of you receive on a WhatsApp when you go fly, you receive some conversational chatbot to support you on whatever problems you have on supporting a service? So there is something which we need to do is democratize health knowledge. We talk about quality of care, we talk about a lot of newer packages being given out, delivered, newer information to be delivered quickly to the health worker. There's a lot of scope of conversational chatbots, which if used correctly, used adequately, can accelerate the adoption. And because it is a newer technology, it is cost effective, it can be much easily adopted. Second part here is something which is not yet there but has a future which I feel could be explored. Again, it is thinking outside the box. In primary healthcare, now we are talking about AI models on a pen drive. So those decision support bots for primary healthcare on a pen drive, or something to do with primary healthcare, data maintenance at a PHC, or how can you, the edge technology which do not require heavy investment. Because one thing when we talk about AI, we forget it is expensive. It is very expensive. As soon as somebody shows me a model, I ask, the first question I ask is economics. How much does it cost? It works, definitely. But how much does it cost? When I get the cost, then the next question is, how much will it cost at scale? Then the numbers go up, exorbitantly. So is what are the ways of innovations of looking at RAG systems, not pure AI, or hybrid systems, which we could look at to democratize the usage of various information. So that is where our future lies. We are the country of Jugaad. So we have to find a way, in a way we can, embed it in our primary healthcare support system. There are a lot of work happening in AI, in predictive, but that's predictive, decision support. I am little bit worried there because we don't have enough data. We don't have enough data to train those models, to test those models. We have to be really, really very cautious. When somebody says the predictability is 95% or accuracy is 90%, I really want to question myself. Really, in real life, we need to be really, really very careful in those. We need to have very stringent, like clinical trial methodologies for evaluating those models. I think government has already taken those steps in the form of both, if I'm not mistaken, or evaluating those things. But yes, there's a lot which can be done on conversational chatbots in terms of decision support, knowledge democratization, and knowledge transfer. So it increases the speed of transfer, because again, this is from my polio days, sir. That the chai samosa training which we used to do, those days are gone. The A&M is more excited to learn it on a WhatsApp chatbot than a chai samosa training, which we were used to in 2000s. So that's something which is new to her, and that's something which we need to kind of look for newer mediums of providing the trainings and knowledge.
Thank you so much. So you have raised many pertinent issues. One is that can we increase the speed of dissemination of knowledge across the various cadres of healthcare providers, right? We have talked about age deployment. Can we think about having some sort of offline models of AI tools that can be easily, readily be available at the primary healthcare setting? And again, CDSS systems, can we leverage existing available data to come up with more nuanced, I would say, decision support tools? Thank you so much. Coming back to Maulik sir, as we already have know that many of the AI tools are entering in India's healthcare ecosystem, whether it is for screening or triaging or supporting diagnostic or decision support, etc. But it has been observed many a time happens that these particular tools which were created on the data set might not be representative of the actual ground realities. So from your implementation experience, what happens when such design gap meets the ground reality of ASHAs, ANMs, and the public health system on ground, and what we can do, what sort of changes we can, propose to ensure that the scale happens at in a responsible fashion when we are moving for a national, state to from pilot to state to national level scale up.
I think so. I think so. The answer is very simple. We fail, right?
Right.
If you bring in kind of models which are trained on international data set, right? We don't get outcomes desired at a practitioner's level.
Right.
Now, doctors are the most monopolistic, and I'm sorry to use this word, monopolistic segment, right? If they don't get what they want, they won't use it. They won't even try using any innovation coming forward.
Yeah.
So if we lose trust of a practitioner, right, then it's a very costly affair to reintroduce that particular application to a doctor or a practitioner. But further alarming is the kind of effect it can have on the beneficiary, right?
Yeah.
The patient. I'm not using the word patient category, but I'm using the word beneficiary. that if there is if the predictive analysis is not to the mark and is not assuming the conditions prevailing in Indian ecosystem, then it does not meet your health system objective, which is health outcomes. That's again is a big price to pay by using models that are trained on large models trained on different data sets which are not in India. So if I go back to kind of a clinical trial analogy, right? Second point that we need to take care is what works in vivo and what works in vitro, right? Predictive analysis trained on large learning models might work fantastically well on a tablet or on a PC. But when that PC is placed in an OPD with a 250 patient load, with 4 practitioners working at the same time, and we want to use AI out there, and giving an example of a voice to discrete data set, it's not going to work, right?
Yeah.
So what we need to do is that it's important to create these models based or trained on Indian data sets. But after that model is developed, I think so there needs to be an ecosystem that needs to be created where it is tested in terms of real world evidence. If I go to the economic evaluation as a health economist, so the RW is more important than anything, right? So if that model is working in real world situation or not, and I think so for AI, we need to create that real world evidence test case sites. At the moment, we don't have test case size. If I want to go and do a test case, I don't have test case size. The test case size gives me multiple things. Firstly, it helps in making sure that what my model is trained and the outcome it is delivering is aligned to what real world evidence is, number one. But simultaneously also starts in creating my local data sets, which could be then further used for training my models. So I think so that creating the data sets with multiple combination, it's OPD versus labor room versus IPD in medicine. Right. So we need the public sector, private sector, rural setting, urban setting, peri-urban setting. So we need to create that environment where this real world evidence is generated, where AI application is used to a test case.
Right.
If we are able to do that, I think so, then it also builds confidence into practitioner. Hey, whatever I am saying, at least it has got 90 to 90% of congruency in my outcome.
Right.
And so that's very, very important, because again, I'm going back to my earlier statement. If a monopolistic doctor once said, I don't want to use it, and I'll give you an example of a very dear friend. He is a lead pulmonologist in one of the biggest 650 bedded hospital in South Delhi.
Okay.
And I asked him, कि you have this OCA, right? उस पे क्यों नहीं लिखते हो? यार एक तो यार पेन से लिखने में बहुत मजा आता है और फिर कुछ गड़बड़ हो गई ना तो फिर प्रॉब्लम हो जाती है क्योंकि वो डॉक्यूमेंट हो जाता है, राइट? योर डिजिटल फुटप्रिंट इज ऑलवेज देयर, so they are very worried about this kind of situation. So making sure that whatever they are going to use is 100% foolproof, or at least they have got enough confidence in using that is important. So at a research perspective, I think so we need to create that evidence, taking those models, getting into test use cases, and creating data set which can further evolve. Thank you.
Yeah, thank you. Very well said, sir. So the main takeaway is that we essentially have to come up with some kind of test sites across India where we can actually try and test the coming models in the actual reality. Because we have been doing a lot of simulation-based testing and validation, but we have been so far not doing the actual reality.
Pressure test to them.
Yeah.
If I use Anurag's word, pressure, we are not pressure testing enough.
Coming to you, Dr. Anurag, Ashoka University has played a very critical and important role in conveying initiative like Sahi and Bodh. Could you help us understand why such frameworks and governance conversations and such events are so important for India's emerging AI ecosystem, especially when we are to grow exponentially?
Thank you very much. I'm going to partially continue on the previous track, because to be very honest, when I look back at what we did, which was the consultations before Sahi, supported by people like Kanaita, and of course with the wisdom of people like Malik, what was the most important thing we did is, bring in the combined wisdom as you're doing now, right? But what was it really about? I mean, if you think of Sahi, really, it's 5 pillars that we thought about. You can think of them in a sequence. You can think of them as governance. You can think of it as data that we keep on referring to over here. Then you're thinking of people, which again is what we were talking about. You know, you can build all the models you want. Without the people using it, it doesn't matter.
Doesn't matter.
And then research, because you can be certain, even with the data, even with the people, things will go wrong. And unless you do implementation research to know what goes wrong, you will never correct it.
Yeah.
That's, I think, Ajay's point as well. And last again is ecosystem. All these things are health. Health is just one part of life, and there's a larger ecosystem in which you have to frame this. In fact, you would argue that India's digital health vision is successful because we didn't start with digital for health. We started with digital for finance, for ID, where everybody needed it,
Right.
right? Health was anyway going on, doctors were fine, patients were fine, but digital in finance, digital in payments, digital in ID transformed the ecosystem, made it worthwhile for people to invest in digital, and then we piggybacked our digital ambitions on top of it, digital architectures, right? But the key thing that we learned during these consultations was change management. And I still remember it because the first time somebody brought it up, they're like, everything is fine. Tell me why a healthcare worker would want to use it. And I thought to myself, forget healthcare worker, why would a doctor want to use it? If I say AI will increase the efficiency, they can now see 50 patients when they could see 40. And I think of myself in that seat. Now I can see 50 before I could see 40. Probably you're cutting down on my few minutes of thinking and rest in between. And am I going to get paid more? Is my life going to get easier or harder? One of the two has to occur. So which means AI needs to be positioned to make lives better on both sides. Not just the patient side, but also on the healthcare deliverer side. I'll tell you a very small story which is part of what historians call formatting of technology to purpose. Technology changes things, right? But formatted technology, suitable to purpose, changes much more. X-rays are discovered 1897. The first X-ray machine is 1898. University of Pennsylvania gets a machine around that time. 10 years later, despite 1,000 papers being written in those days about how X-rays will transform medicine, only half the people with fractures are getting X-rays. And it's free. The chief resident can use the machine, no problem at all. Now instead they hire a person who gets paid every time an X-ray is done, a small amount, and that person can hire more people and radiology happens, right? So the incentive structures must include the people who use AI. Right. That is very important, and the both part. Both is more to do with what was we called stress testing. How much can you trust AI? And the challenge is accuracy is not a proxy to safety. Accuracy is how a doctor functions on a day for an exam, well rested, all prepared, things like that. And safety is how they function after 2 nights without sleep, in a brand new case they've not seen, perhaps even in a setting they've not worked in before. And we must stress test these things. But I'll end with a note of positivity on this. A lot of our discussions with AI and data is built on our experience with narrow AIs. Right? Narrow AIs, if they were not trained on the right data, were guaranteed to be wrong, but also very, very likely to be right in other circumstances. Now we have very interesting Gen AI, and I'll give you one example of AMI, Articulate Medical Intelligence Explorer. There's the conversational AI that Google DeepMind did. And you would imagine it must be trained on conversations. No? Amy the patient, Gen AI, spoke to Amy the doctor, and Amy the critic critiqued the conversation. There is no real data. It's all synthetic. They go round and round until Amy the doctor becomes very good at eliciting history from Amy the patient. And Amy the critic is happy with Amy the doctor. At the end of it, they do 100 objectively structured cases, patients from UK, India, and Canada. 100 primary care physicians, nobody knows who is who. The patient actor is chatting either to a Amy or they're talking to a real PCP. A real specialist rates it on accuracy, management, escalation. The patient actor rates on confidence, honesty, empathy, and Amy wins. And now there is Amy cardiology that's now been shown to help doctors with complex cases and things like this. Limitation, these are mostly actors, although Amy cardiology is more real life. There's also an Amy PCP trial now out. And how to frame it so it doesn't become autonomous is another challenge altogether. But my point is with modern Gen AI, we have a new problem. It can be wrong even on simple cases.
Right.
But we have a advantage, even with small amount of data that is contextual and used for tuning, there is a significant amount of knowledge, for the lack of a better word, already in these AI systems. And my personal feeling is as we go forward, we will start seeing broader applicability, but we'll still require, of course, humans for a variety of reasons, including liability, by the way. But I think we are at the cusp of something very interesting, but we really need well-tested bets. And one thing that we are doing at Ashoka, again supported by the foundation, is imagining how these will be tested. RCTs will no longer be enough. RCTs, if you want to really understand how something works at scale, are the wrong way. Using an AI in a limited RCT simply gives you a more precise estimate of its accuracy in that setting.
Right.
The A/B testing at scale, multiple users across the country trying free downloadable AIs that you can tune yourself to your cases, and this will be called Praman, which is proof. It will be something that ICMR, multiple institutions in India will be part of. Young people, young doctors in training would become typical users. You can use any of these downloadable platforms on a common platform. It allows you to look at which answer was best, benchmark things, and the feedback that you give while using it usefully can be used to improve it, and you can even download whatever you have trained yourself as something that you own. It's a very ambitious vision. I'm very thankful to the foundation for the support, and I truly believe something like this will be a completely reimagined test beds. Some doctor will feel like stress testing, so be it. Some will just use routine cases, so be it. Very long answer, but hopefully it was useful.
Yeah, certainly, sir. So we definitely would want to focus on change management, how we can incentivize the usage of AI in terms of creators, likewise end users. And the last thing that you have said about Praman, can we create some sort of a architecture around where we can, multiple users can simultaneously use the AI technology and come up with bottlenecks, and if we can address those gaps. Lastly, coming back to you, Anaita, could you help us understand where India's health AI ecosystem currently stands today? I know it's a broad question, but the particular question to you is that what role are funders and ecosystem partners are currently playing in shaping, validating, and scaling responsible AI innovations as we move forward?
Thank you. I think Dr. Anurag made my life very easy. He talked about some of the work that we are supporting, and I have had the privilege to work with everybody sitting on the panel, surely by working with the Gates Foundation and more broadly as well. I think just taking a step back, like we were saying, there's a lot of hype, there is a lot of misuse, but there's a lot of promise. For a country like ours, with the diverse population that we have and very differentiated needs as we get into every district, every block, every village, if we were to think about Atmanirbharta, we will have to think about working and developing AI solutions on the edge, because electricity can still be a problem at the facility, loads can still be a problem. But to your question, if you look at the numbers, the India healthcare AI ecosystem is booming right now. So it's about 1.35 billion has been invested. The projection is about 18 billion by 2035. As of 2025, I think there were about 100 deals closed when it comes to leveraging healthcare AI. There is a booming startup ecosystem of about 14,300 health tech startups in the country as of, I think, 2 months back is a number I have. But let's pause here. Where do we all fit in? And where do the problems that we want to work on fit in here? And what do donors like myself in the room think about when it comes to solving for some of these problems, right? I think a couple of things I'll encourage folks in the room where we've been talking about data sets is that please look up the India AI Missions AI Kosh platform, right? Please look at Bhashini, which is the vernacular languages platform that's been developed, which is being integrated by different AI service providers when they think about last mile reach when it comes to frontline workers, as an example, using these technologies better. I remember I was recently in the field and I was talking to one of the ANMs, the auxiliary nurse midwives there, and they're using this application, WhatsApp-based application, generative LLM developed by Arman, where it is trying to help them identify risks for pregnant women much earlier, right? And I was talking to a full room of ANMs and it was super exciting for me as always, but we were just asking them that what's the so what for this for you, right? Like what is different? You were being trained with chai and samosa maybe earlier on as well. They were like, I don't have to wait, and I have sometimes silly questions, so I can just like WhatsApp and be like, इसका जवाब देना मुझे और मेरी language में पूछ सकती हूँ. Sorry, I'm using Hindi. So it becomes easier for me to be able to navigate and then, you know, do some of those things which otherwise I would wait for my lady supervisor to come in or for the block level meeting or the AAA meeting to happen, right? I think to Maulik's point, make it really real world in terms of what is the day to day that can be solved for. I think that's number one where we see our role. We see our role in being a facilitatory body in different mechanisms to actually put the design and the need first before developing the technology. Technology, as you all will work on, is the easiest thing to crack when you're thinking about population scale. Everything that comes after is or before is most important. So when you're thinking about technology, a lot of times because we are so passionate, we think about the solution and we end up force fitting it. Think about it from the perspective of the person who's going to use it, whether it's on the demand side, whether it's supply side. So when we make investments, when we work with partners with the expertise available in the country, we try to ensure that the right people are in the room. A second part to this is working with the private sector. I mentioned some stats. There is a very thriving innovation ecosystem in India across the value chain. There is a lot of investment that's happening in imaging, diagnostic screening, tertiary care, HISs, so on and so forth, right? But when it comes to truly making these technologies useful for program interventions, what we should be thinking about is the maternal mortality rate of this country, the infant mortality rate of this country, something Ajay and his team are closely working on, right? When you think about that, then you will think about how can some of these private sector solutions be used for these use cases to truly benefit the maternal health journey or the child health journey or infectious disease, early referral, treatment, pathways, preventive care that we've been talking about in service of these program goals. So I would also encourage that to happen, and that's where we also see our role to be. The third piece, going back to the facilitatory layer, I know there is this common understanding or misnomer, if I may say, that funding organization just to fund and that's about it. I think that's like the least bit of problem we are here to solve. There is a vantage point from which we can, you know, work with different kinds of organizations, and it's our responsibility to ensure we play that facilitatory layer. So when it comes to private sector organizations, we know sustainability for these organizations in healthcare is a challenge. Whether it's the large ticket players or the smaller organizations which are truly trying to do service by working on problem statements very close to India or the global south. We had colleagues earlier in the day talking about some of that. How do we catalyze the ecosystem, the innovation ecosystem, the funding ecosystem to solve for some of these gaps? It will be remiss for me to not talk about the fact that working capital is still a constraint for these organizations. When we talk about supporting real world data sites to actually testing sites to actually have the real world evidence, we need to be talking about what would happen once that evidence is generated. Once that evidence is generated, you have, say, a cutting edge technology that's thinking through cost efficiency as well. What are the procurement pathways? How do these organizations think about population level impact? How does government think about the trade-offs when they have to procure such a technology? AI is evolving at such a fast pace. How do they validate for something like that to what Dr. Anurag was mentioning? So I think these are some of the ways we think about ourselves, but at the core of it is de-risking early on, catalyzing and playing that facilitatory role in a much more strategic manner in service of what the country needs. I think We work closely with the government and some of these experts in the room purely because they're on the ground. They know exactly what's required, and we can't be sitting in boardrooms, conferences, thinking about what that is.
Yeah, very truly said. So we have to be sort of play a complementary sort of a role, an enabling role, moving forward. As we are closing towards end of our panel, now I would like to close with one common question for all of you. We already have so many young part practitioner, innovators, and students in the room today. So, what is the one message that you would like to leave them about the future they are inheriting, or maybe they can shape in changing the coming India and AI landscape? Yeah, please.
We go this way, this way.
No, I think it's very, I mean, you are the generation that is natively digital, and you are the first that will see a completely face or digital health systems within your life. And although you are very young, within a short amount of time, you will be the first generation that will have the next generation that will completely face a new vision of health altogether.
Right.
I think ask questions and challenge, because a lot of change is about to happen. Not all change will be for the good. Understand and challenge.
Thank you.
I would just extend that there is humongous amount of opportunity. If you ask me, I'm an old school guy. I'm not as versed as Dr. Anurag is. I'm an old school guy. But for you, there is humongous amount of opportunity, because health system still has got lot of challenges to be addressed. So that opportunity helps you to pivot to a next level. And it's not only you. I think so globally also now India is looked as a big brother, if I may say so, where they are looking at new DPGs, new solutions emerging out, which was even shared earlier. So I think so that allows you to play both a role in kind of what we can create for our country and what we can create for global South, because we are in a way say that we are a cost sensitive producer, and that cost sensitive production can really help in leapfrogging in this kind of tight global financing situation.
I'm somewhere in the middle, so I'm just going to say sorry and thank you. Um, sorry, because I think there is a lot more that we could have done so far in terms of the right kind of test cases, use of AI, adoption of AI, to be actually able to expedite this so that we are very clear on what the human in the loop really needs to look like. Grateful because you're helping ask us the right questions. I do want to call out that I think healthcare, whether it's digital, AI, technology, etc., firstly starts with the very basic fundamental that do we all care for our own health? Digital finance, I mean, DPI for finance and inclusive financial growth truly mattered because we do care about how we are spending our money and how we are saving money, etc., right? So that really picked up very fast. The incentive structure here depends on each of us. So that's something that I wanted to just call out. Two, the opportunity is real. Once you start thinking about who the target audience for you is, who that target citizen, beneficiary, patient, whatever we might call it is, you will be able to think from their shoes perspective. You will be able to understand what they want to do. So my second request is, and I've started the conversation with this, please go into the villages of India. Spend time on what the actual requirements are. Spend time on the cultural context to truly understand how healthcare is being perceived for different disease areas. We have government in the room. Spend time with them to understand what the real needs are on the ground. And the third piece is, we've not been able to crack this fully because of the first two, which is the 0 to 1 game, right? We started thinking about digital solutions. We started thinking about what the needs are. There are these tech startups which are coming in. Some of you will go on to become entrepreneurs in this area. Think about the sustenance of some of these. How do you think about that, whether it's in India, whether it's in Africa, in the global South? We need to be able to do a lot more cross-sharing so that we don't keep reinventing the wheel, and I'd strongly encourage that.
Again, let me tell you, losing a lot of my black hair to gray, this working on some of the intervention, you are inheriting something good. what is there in place is something which is world class. But there is a lot of scope. As they say, we still have minimum viable product. And I also say this when in a lot of my discussions when we were designing the last project, that every Taj Mahal starts with a 2 BHK. So we are still at a 2 BHK state. Taj Mahal is yet to be built. But that Taj Mahal has to have one center, which is the either the health worker at the center, or the mother or the child or the user at the center of it. Because we have enough digital tools and enough digital data which is going up, but use of data is going to define how this thing evolves, and how can we reap the benefits of what we have done so far. What Anaita said, we don't have to reinvent the wheel. We have to make a lot of these digital public goods and try to provide it to the world as you know, like we did in other domains as a country.
Thank you so much. So I think in a nutshell, the problem is right now is of prioritization and optimization instead of creating something new. Thank you so much to all our panelists for such a rich and thoughtful discussion. Now let's open the floor for some questions from audience. Please requesting everyone to keep your questions brief and specific, and if you want any particular panelist to answer the questions.
थैंक यू मैम। सर मेरा नाम अमित है, मैं जयपुर से हूँ। सवाल भी हैं और थोड़ा समझ में भी आया, हालांकि अंग्रेजी समझ में नहीं आई, लेकिन एआई से ही इस्तेमाल किया है, जैसा जैसा बोला उसको रिकॉर्ड करके समझने की कोशिश की है। मुझे समझ में आया कि थोड़ा इंफ्रास्ट्रक्चर पे भी काम करने की ज़रूरत है, साथ में ट्रेनिंग्स और नॉलेज, तीनों चीज़ों को कंबाइन करना चाहिए अगर एआई का है तो। एआई से एक बेनिफिट होगा कि हम एक तो टाइम बाउंड होगा, और जो हेल्थ को ख़ास तौर पर वो सटीक इन्फॉर्मेशन मिल पाएगी। और इसका एग्जांपल मैं दे सकता हूँ, मेरे हर्निया की प्रॉब्लम थी, मैंने एआई से ही उसको एग्जैक्ट निकाल लिया, और किस तरह की जांच होती है वो निकाला और डॉक्टर के पास पहुंच गया। बस इतना ही गैप रहा, एआई ये नहीं बता पाया कि कितना एमएम का गैप था उस हर्निया में, बस ये, और बाकी चीज़ सारी इन्फॉर्मेशन ले ली मैंने। तो मैं डॉक्टर से कंसल्ट करने के लिए रेडी था, मुझे पता था कि मुझे किस डायरेक्शन में जाना है, और मुझे सही इन्फॉर्मेशन मिल पाई एआई के थ्रू। मेरा ये बहुत आसान है, लेकिन ये बहुत टिपिकल भी है। जैसे मैम ने बताया कि रूरल एरियाज़ में इस तरह से आज भी मोबाइल फ़ोन नहीं है, एआई का नाम नहीं जानते लोग, लेकिन गवर्नमेंट और सब लोग प्रयास भी कर रहे हैं कि डिजिटलाइजेशन होना चाहिए चीज़ों का लेकर, जिससे कि टाइम बाउंड और सटीक इन्फॉर्मेशन मिल सके। तो मेरा सवाल ये था कि क्या गवर्नमेंट का कोई ऐसा विजन है कि हम 10 ईयर, 12 ईयर या 15 ईयर या 5 ईयर्स में हम पूरा डिजिटल कर देंगे, हेल्थ को लेकर एआई बेस्ड बना देंगे, ऐसा कोई विजन है गवर्नमेंट का? ये जानना था मैम मुझे।
हेल्थ हमेशा एक चीज़ याद रखनी पड़ेगी कि बच्चे वैसे ही पैदा होंगे जैसे होते थे, सर्जरी ज़्यादातर वैसे ही होंगी जैसे होती थी, और इसलिए डिजिटल एक सीमित तक काम करेगा, उसके आगे फिज़िकल इंफ्रास्ट्रक्चर कभी ख़त्म नहीं हो सकता। और एक जो रिस्क आता है कई बार कि हमें लगता है कि एआई से बहुत सारी चीज़ें सॉल्व हो जाएंगी, एआई बहुत बार गलत एडवाइस भी देता है। कई लोग हॉस्पिटल पहुंच चुके हैं एआई का एडवाइस लेके, उसके पहले डॉक्टर गूगल का एडवाइस लेके, आजकल मतलब डॉक्टर जीपीटी का एडवाइस लेके। तो हेल्थ का जो मिस इन्फॉर्मेशन भी हो सकता है एआई के थ्रू, क्योंकि जब आप एआई से सवाल पूछते हैं तो आपने क्या क्या सही बताया, क्या क्या चीज़ें थी जो पूछनी थी। जनरल पर्पस के लिए फिर जीपीटी ने जीपीटी हेल्थ भी निकाला था, जीपीटी हेल्थ के फिर थोड़े ख़राब रिव्यू आए तो आजकल जीपीटी हेल्थ थोड़ा डाउन है फिर से। मेरा ये है कि फिज़िकल इंफ्रास्ट्रक्चर कभी नहीं ख़त्म होने वाला, उस पर फोकस करना भी बहुत ज़रूरी है। एआई को एक लेयर की तरह कन्वीनियंस, इंटरेक्शन, प्रोसेसेस वो आज तक वहाँ पे पहुँचा है और काफ़ी रिसर्च चाहिए होगी जब तक हम वहाँ पे पहुँचें कि एआई का जो एडवाइस है वो ऑलमोस्ट गारंटीड सेफ्टी के साथ आए, उसमें भी वक्त है।
No more question?
सो सही जो इंडिया की जो एआई स्ट्रेटजी है उसमें एक काफ़ी इंटरेस्टिंग लाइन थी, इनोवेशन ओवर रिस्ट्रेंट, बोरोड फ्रॉम द आरबीआई स्ट्रेटजी। बिकॉज ये हम जानते हैं कि इंडिया पीछे है, हमें आगे बढ़ना है, तो इनोवेशन ज़रूरी है। सिर्फ रिस्ट्रेंट में रुक गए तो प्रॉब्लम हो जाएगी। उसकी अगली लाइन है रिस्क कैलिब्रेटेड गवर्नेंस। लेकिन इसमें भी हम ये सोचेंगे कहाँ पे नुकसान ज़्यादा हो सकता है, कहाँ पे नुकसान कम हो सकता है। जहाँ नुकसान होने की संभावना कम है वहाँ पे एआई को तेज़ी से बढ़ाया जा सकता है ताकि ऑल डिजिटल, ऑल एआई फ्रंट लाइन। और जहाँ पे नुकसान होने की संभावना ज़्यादा है, जो डिसीजन आप वापस नहीं ले सकते, एक बार आपने किसी स्ट्रोक पेशेंट सोचते हुए थ्रोम्बोलिटिक दे दिया तो अब उसको वापस नहीं ले सकते। किसी पेशेंट को आपने टीबी समझ के आगे फर्दर इवैल्यूएशन में भेज दिया, वो डिसीजन वापस हो सकता है। एंड ये इंडिया की काफ़ी इंटरेस्टिंग स्ट्रैटेजी है जो बोरो एक चीज़ से करती है कि बहुत सवाल जो दुनिया में आता है, एथिक्स ऑफ ऑल दिस, राइट। आई विल स्विच बैक टू इंग्लिश बिकॉज आई एम कोटिंग समवन कि एथिक्स नॉर्मली एवरीबडी एग्रीज कि ओनली ए पर्सन हु कैन डू समथिंग विदाउट द एआई, जो आदमी बिना एआई के कोई चीज़ कर सकता है उसी को एआई का इस्तेमाल करना चाहिए। अगर हिंदुस्तान में हमने ये वाली एथिक्स ली तो हमारे जो बड़े एम्बिशन है वो तो हो ही नहीं सकते, क्योंकि वो लोग ही कम हैं जो बिना एआई के कर सकते हैं। सो जैक कोहन wrote a very interesting line, ethics in AI should be based on the health system you have as opposed to be the one that you wish you had. So ये हमें ध्यान रखना पड़ेगा और ये सरकार को सोच रही है, लेकिन हम सबको भी इस कमरे में सोचना पड़ेगा क्योंकि इसका फ़र्क किस पे पड़ता है, आप सब पे ही पड़ता है।